Welcome to the deep dive. Today, we are strapping in and going straight into the surgical playbook. We're kind of bypassing the usual intro reviews and hitting the core biomechanical stuff, the epi details. Basically, the things that are absolutely non-negotiable if you're planning spine surgery or, dealing with tricky peripheral instability.
Exactly.
Our deep dive today is all about those foundational concepts, pulling directly from, well, the highest level surgical text.
That's right. And look, we've got a dense stack today.
Oh.
It's really designed for you, the learner, who needs to shortcut that path from just being familiar to actually being competent.
Right.
Understanding these specific numbers, the pelvic geometry, which is fixed, the weights of curve progression, knowing exactly when to get that MRI in trauma, that's the difference.
Yeah.
It really is.
Yeah.
Dissecting scoliosis, the technical dangers in spondy reduction, C-spine trauma protocols, and even specific knee kinematic tests. It's a lot, but it's core stuff.
So, our mission is clear. Distill the key parameters, progression rates, the critical diagnostic steps, straight from the sources to give you that expert level foundation. We're jumping straight to the core principles. Let's start, fittingly, with the foundation itself. Alignment. Okay, let's define the battlefield first. Adult idiopathic scoliosis. AIS.
Right.
So we're talking a coronal curve, got to be over 10 degrees, with structural changes, and importantly, the patient's skeletally mature, usually over 20.
Yeah, although clinically, you often see them presenting later, right, late 30s, 40s, when symptoms actually start kicking in.
Exactly, when the pain starts.
And critically, it follows that same pattern we see in adolescence. Women are affected way more often than men, sometimes, 4-to-1 for the curves that actually need attention.
Wow, 4-to-1.
Yeah, and if you look across the whole adult population, the prevalence for any curve over 10 degrees is somewhere around 2 to 4%.
Okay.
The real challenge, though, is sorting out the ones that are symptomatic and getting worse from the ones that are just there. Stable findings.
And sorting them out means predicting the future, doesn't it? Especially if you're thinking about fusion. You have to treat these curves based on their quantifiable risk of getting worse.
You do.
It's actually surprisingly predictable once you hit certain thresholds.
It absolutely is. It's the calculus of curve management. Think of these progression rates like actuarial tables, risk factors you track over years.
Like tracking stock market metrics, maybe?
Kind of like that, yeah. You're watching the long-term volatility. You need to know when to intervene, when to stabilize.
Okay, and the sources, they point to Weinstein and Ponsetti's work, giving us specific goalposts. Depends on location and size.
That's the classic data.
So for thoracic curves, progression is generally expected if they're over 50 degrees.
50 degrees is the key number there.
And in that range, they tick along at about, 1 degree per year?
Roughly 1 degree per year, predictable. But, and this is important, it's not linear forever. The progression actually slows down quite a bit once the curve hits about 75 degrees. Then it drops off maybe 0.3 degrees per year. And it typically stops altogether around 90 degrees.
So there's a natural ceiling almost.
There is. It helps with the risk analysis for those really big established curves you sometimes see.
So if you see, say, a 55-degree thoracic curve in a 40-year-old, assuming no major degenerative changes, you've got maybe a 15-year window before it potentially hits 70 degrees and starts causing real problems.
That's the kind of thinking, yes. Now, compare that to lumbar curves.
Right. Different beast?
Totally different beast. They're much more aggressive in terms of when progression kicks in. You only need to hit 30 degrees.
Only 30 compared to 50 thoracic.
Exactly, 30 degrees. And that progression mechanism turns on. And once it does, they move steadily at about 0.4 degrees per year.
Okay, 0.4, slower rate, but starts much earlier.
Right. And that difference tells you immediately why a, say, 35-degree lumbar curve needs much closer watching, maybe earlier intervention, than a 35-degree thoracic curve might. The lower spine just takes more load, different mechanics, more vulnerable.
And the why behind that progression, it's not just bone growth anymore in adults, is it?
No, absolutely not. In adults, late-stage progression is really driven by mechanical breakdown, progressive disc degeneration, loss of rotational stability.
Makes sense.
As those discs lose height, especially on the concave side, the rotational part of the deformity gets worse, and that just feeds back into more instability at that level. It's a vicious cycle.
Wow.
Lose interior support, rotation increases, drives progression faster than that baseline 0.4 per year. Overall, the data suggests something like 68% of adult curves will progress more than 5 degrees over time, so you have to watch them.
Surveillance is key. And not all lumbar curves are the same risk-wise, right? The sources mention specific predictors.
These are your red flags, the things you look for. First one is L5. If L5 is sitting above the intercostal line. High writing, yeah. That increases risk, suggests an inherently mobile setup. Second, high apical rotation. Specifically, more than 30% rotation at the apex.
Okay.
Third, is the curve decompensated? Is the patient unbalanced? Does that C7 plumb line fall way off?
Global alignment matters.
Big time. And finally, a big thoracic curve tagging along. If there's a thoracic curve over 50 degrees, that increases the risk for the lumbar curve too. Bigger lever arm, more stiffness globally.
Got it. Okay, moving from coronal to sagittal. We have to nail down spinopelvic alignment. This feels really foundational. Pelvic incidence, pelvic tilt, sacral slope, PI, PT, SS.
Absolutely foundational.
The sources even point to figure 39.59 for visualizing these.
And this is where, honestly, the technical knowledge really separates people. Pelvic incidence, PI. It's the anchor. Let's define it precisely because it matters.
Okay.
It's the angle between a line perpendicular to the middle of the sacral end plate and another line drawn from that same midpoint up to the center of the hip joints, the bicoxifemoral axis.
Okay, that definition is a mouthful. But the implication is the key, right? Why do we call PI the takeoff degree?
Right. The absolute key takeaway, the thing you must remember, is that PI is a fixed morphologic parameter.
Fixed?
Fixed. It's baked into the shape of the pelvis. It does not change after you stop growing. It's your spine's architectural demand for lumbar lordosis, for LL.
So it dictates how much curve the low back needs.
Exactly. The PI value tells you the target LL needed to stand up straight, basically. The goal is usually LL equals PI plus or minus about 9 degrees. That's the sweet spot for balance.
And the average PI is around 52 degrees, give or take 10?
Yeah, 52 plus or minus 10 is the population average. So if you have a high PI, say 65,
yeah,
your lumbar spine needs more lordosis, maybe 56 to 74 degrees worth, just to keep your head over your hips without struggling. Low PI, need less lordosis.
And you can't surgically change the PI.
Can't change it. You can only surgically restore the lordosis needed to match it.
It's like the foundation of a building, right?
Perfect analogy. You can't change the foundation depth, that's PI, but you have to build the skyscraper, the LL, to the right height to keep it stable and upright.
And if you fuse someone flat, ignoring their PI.
Big trouble long term. Poor stability, more pain, adjacent segment problems. You're fighting their inherent geometry.
Which brings us to the dynamic angles, the ones that can change, like pelvic tilt, PT.
Right. PT is the variable one. Yeah. This is how the body compensates.
Compensates for what?
For being pitched forward. When a patient loses that required lordosis, they try to maintain balance by tilting their pelvis backwards. Retroversion, that tucking action, that's measured as pelvic tilt.
Ah, okay. So if PT is high, they're working hard to stay upright.
Exactly. They're compensating aggressively.
Yeah.
If PT starts climbing, say, above 20 degrees, that patient is sacrificing a comfortable stance just to keep their head up.
And if they compensate too much, they can still be unbalanced forward, right?
Yeah.
And that's the SVA.
Precisely. The sagittal vertical axis, SVA, that plumb line from C7 down, ideally it falls over the posterior superior corner of S1. If it drops way out front, more than about 5 centimeters.
Yeah.
That's true global sagittal imbalance. The compensation isn't enough. So you see, PI is fixed, PT is variable compensation, and SVA tells you the end result of that balance equation. You have to respect all three.
Okay, so we know the alignment goals, the geometry we need. Let's talk tools. Modern deformity surgery. It seems like it's pedicle screws all the way now, right?
Pretty much. We're definitely past the era where hooks and wires were the main anchors for big constructs.
And why is that? Just better grip.
It's clear, measurable biomechanical superiority. Pedicle screws give you segmental fixation. You control all 3 columns of the vertebra.
How many columns, right?
Which is absolutely vital for the complex derotation and translation moves you need in deformity surgery. But it's not just control, it's stability.
Okay.
Importantly, they're placed outside the spinal canal. Extraspinal, so you avoid that old problem of hooks or wires taking up space inside the canal. The space-occupying phenomenon.
Exactly. Less risk of bumping into nerves after you close.
And crucially, for the older patients, the ones with maybe not so great bone, osteoporosis.
Huge advantage there. The screw gets cortical fixation through the pedicle. That's much stronger than any hook resting on the lamina or posterior bits.
Game changer for the osteoporotic adult spine.
It really is. Much more predictable anchoring when bone density is iffy.
The main risk then is putting it in the wrong place.
That's the one. Malposition. You can hit the big vessels out front, the aorta, vena cava, or posteriorly, you can hit the cord, the dura, nerve roots.
Yeah, I think every resident remembers their first uh-oh moment with the pedicle finder.
Chuckles.
Yeah.
We all do. That's why we drill the safety checks constantly.
Yeah.
Palpating all 6 borders of the pedicle tract after you place the screw. Feel the floor, feel the walls, feel the roof.
Tactile feedback. Still king.
Still better than just trusting the fluoro or navigation sometimes. You need that feel. Okay, speaking of forces, let's quickly review the basics. How do we use these screws to actually shape the spine sagittally? Compression versus distraction.
Got to use the forces smartly. To create or restore lordosis, which you mostly need in the lumbar spine, right, to match that PI.
Yeah.
You put the screws on the convexity of the curve, the outside, and then you compress them together along the rod.
Compress on the high side.
Right. Compression shortens the back, pushes the vertebrae into lordosis. Conversely, for a typical thoracic curve, where you often want to restore some kyphosis.
The normal thoracic round back.
Exactly. You put the screws on the concavity, the inside of the curve, and you distract them. Pull them apart along the rod.
Okay, so distraction lengthens the inside, pushes it into kyphosis?
Lengthens the concavity, drives kyphosis. Simple mechanics. Compression makes lordosis, distraction makes kyphosis.
That's the basic principle, though you have to treat compensatory curves appropriately too, I guess.
Absolutely.
Yeah.
If you've got a flat back below and a compensatory hyperkyphosis up top in the thoracics, you might compress up there too to flatten the excessive kyphosis. The strategy always comes back to the final sagittal alignment dictated by that patient's PI.
Makes sense. Okay, switching gears slightly. Specific pathology. Adult low-grade isthmic spondylolisthesis, usually L5S1, non-op first.
Almost always, unless there's a severe neurodeficit right off the bat. Start with maybe a short rest period, anti-inflammatories, but mostly a really good trunk stabilization program. Physical therapy is key.
And the big no-no activity-wise.
Avoid extension. Things like certain yoga poses, back bends, anything that increases shear across that pars defect.
Got it.
Most folks, especially younger adults, 20s to 40s, with low-grade slips, they can often get back to full function in 8-12 weeks if they stick with the stabilization exercises long-term.
But when surgery is needed, maybe refractory back pain, radiculopathy, things getting worse, you need fusion, right? Circumferential.
Need circumferential,
Yeah.
High fusion rate is critical there because of the shear forces.
So preferred technique, TLIF.
Generally for low-grade isthmic slips, the transforaminal lumbar interbody fusion, TLIF, usually combined with a posterolateral fusion, PLF.
Why TLIF?
The TLIF lets you get into the disc space from the back, clean it out, put in a cage, restores that critical disc height, increases the surface area for bone to grow across, plus you get your posterolateral fusion on the back. Gives you that 360-degree fusion construct, helps restore alignment too.
Okay. So when would you reach for an A-LIF, the anterior lumbar interbody fusion? Coming from the front seems simpler for the disc work sometimes.
ALIF is usually plan B, or for specific situations. 1, if the patient has tiny transverse processes, making a good PLF really hard.
Right. No place to put the bone graft.
Exactly. Or 2, as a salvage, if a posterior fusion didn't take, failed to fuse. Going in anteriorly gives you a clean shot at the disc space without dealing with all the posterior scar.
There's a big warning label with ALIF, especially in certain patients.
A huge one. Non-negotiable consent point. If you're doing an ALIF on a young male patient, you must clearly discuss the risk of retrograde ejaculation.
Because of the nerves you have to move.
Yeah, the sympathetic plexus that controls ejaculation runs right near the L5S1 disc space anteriorly. Risk isn't super high, but it's real and potentially permanent. Got to discuss it.
Definitely. Okay, back to the posterior surgery for spondy. Reducing the slip. Getting L5 back on S1. You said this is high risk.
Arguably one of the highest risk maneuvers we do routinely in spine, specifically because that L5 nerve root is draped right over the edge, getting stretched as you pull the vertebra back.
And the temptation is always to get that perfect anatomical reduction on the X-ray, grade 0 slip.
The temptation is strong, but you have to resist it if the nerve complains. We have really compelling cadaver data on this. It quantifies the risk beautifully.
What did it show?
It showed that during the first half of the reduction, the first 50% of pulling it back, only about 21% of the total nerve strain happens.
Okay, so far so good.
But the remaining 79% of the measured strain, that all happens in the last 50% of the reduction as you get closer to anatomical.
Whoa, 79% in the last half. That's incredibly nonlinear. Risk explodes at the end.
Explodes. It's a perfect example, like stretching a rubber band, right? It's easy at first, then gets exponentially tighter just before it snaps.
So it's like pushing a rope past its breaking point, as the analogy goes.
Exactly. Once you've taken up the slack, the tissues around the L5 root are taut. The tiniest bit more pull creates massive strain on that nerve.
So practically, in the OR, you're reducing neuromonitoring alarms go off for L5. What do you do? Do you accept less than perfect reduction?
You absolutely have to. If you see definitive EMG changes, a sustained drop in the L5 motor signal, you stop. You back off the reduction force immediately.
Even if it means leaving a grade 1 slip instead of getting that perfect grade 0.
100%. You accept the residual slip. A stable fusion, even with a slight residual slip at a healthy nerve root, is infinitely better than a perfect X-ray with a foot drop.
What are the long-term consequences of leaving that slight slip if you get a solid fusion?
Generally minimal. If the fusion takes and you've restored disc height, the biomechanics are usually fine. The consequence of paralyzing that L5 root, devastating, life-altering, not worth the risk for that last millimeter of reduction.
Okay, sharp pivot now. Acute trauma. C-spine fractures, spinal cord injury, initial assessment.
It's pure ATLS first, right? ABCs.
Always. Airway, breathing, circulation. Stabilize the patient first. Spine comes after the primary survey.
Then the ortho workup starts.
Immediately. Thorough history if possible, comprehensive physical exam, palpate the neck carefully for tenderness, gaps, step-offs.
And looking for those cardinal signs of SCI.
Gotta look actively. Flaccid limbs, incontinence, priapism, those suggest cord injury, potentially neurogenic shock.
And every single finding, motor, sensory, has to be meticulously documented. On the AJ form, American Spinal Injury Association standard, motor levels, sensory levels, light touch, pinprick, rectal tone, bulbocavernosus reflex. That form is the patient's baseline. Legal document, clinical roadmap, everything.
Right. Now, the goal in the awake, alert patient without obvious injury is get the collar off safely, ASCP.
Definitely. Those hard collars cause problems.
Yeah.
Pressure sores, aspiration risk, hinder airway management. So we want them off if it's safe, which relies on clinical clearance.
Based on the NXES criteria, the 5 criteria, that's the benchmark.
Gold standard for ruling out significant injury clinically in the right patient.
And just to refresh those 5 for everyone listening, no posterior midline C-spine tenderness, no intoxication, normal alertness, no focal neurodeficits, and no painful distracting injury elsewhere.
You got to tick all 5 boxes, yes.
And the data supporting NAHUS is pretty strong, isn't it?
Very strong. The sources mentioned Rose et al.'s study. Huge numbers. Found 99% sensitivity, 99% negative predictive value for clinical clearance in alert blunt trauma patients, even if they had a distracting injury somewhere else.
Wow, 99% even with a distracting injury.
Yeah. And their conclusion was pretty striking. Applying NXUS safely could potentially cut down the need for C-spine CT scans by something like 61% in that group.
61% reduction? That's massive for resource use, radiation.
Huge implications for trauma centers. Cost, throughput, radiation dose. That's why these clinical decision rules are so vital.
But when you do need imaging, what's the go-to now? Plain X-rays?
Not really anymore for the initial assessment, especially if there's high suspicion or polytrauma. The modern standard is multi-detector CT, MDCT, with good sagittal and coronal reconstructions.
CT for bones and alignment.
Much better than plain films for seeing bony detail and subtle malalignments.
Okay, so when do we bring in the MRI? This seems to be where the debate often lies. Cost, time, utility.
MRI is your soft tissue tool, essential for looking at the ligaments, especially the posterior ligament complex, or for spotting disc herniations caused by the trauma.
And those non-contiguous injuries.
Right. Injuries at other spinal levels. MRI is good for screening for those too, which happen in maybe up to 15% of spine fracture patients. Things on CT that might make you lean towards MRI include widening between the spinous processes or significant prevertebral soft tissue swelling, like more than 5 millimeter at C3.
But the question is, does finding those things on MRI actually change what we do? The Schoenfeld study is cited here.
That's a key study. It showed MRI found about 8% more injuries than CT alone.
Okay, sounds significant.
But only 1% of those extra injuries found only on MRI actually needed surgery. 1%.
1%. That leads to the NNT discussion, right? Number needed to treat.
Exactly. The number needed to treat, or in this case, number needed to scan with MRI to change patient management in any way, like going from collar to surgery or adding more observation, was 50. 50 MRIs to change management for one patient.
50. And the NNT just for surgery?
Even higher. NNT for surgery was 167. You'd need to scan 167 patients with MRI who had otherwise normal CTs by certain criteria to find one who needed an operation based only on the MRI findings.
167. That really puts the cost benefit into perspective, doesn't it? Makes routine MRI seem hard to justify.
It does. The data strongly suggests MRI should not be routine if the patient's neurologically intact. alert, and the CT looks okay by established criteria. You need a specific reason, a neurodeficit, high-risk mechanism, obtunded patient you can't clear clinically, or suspicious CT findings.
And if you are getting an MRI, timing matters.
Big time. For seeing the acute stuff, the hemorrhage, the edema in the ligaments, or cord MRI sensitivity is best within the first 48 hours.
Okay.
After that, the edema might resolve, and you're relying more on seeing actual tissue disruption or subtle malalignment. So for those obtunded patients you can't clear, getting the MRI within that 48-hour window, if they're stable enough, is pretty important.
Got it. Before we leave trauma, quick clarification. Neurogenic shock versus spinal shock. Two different things, easy to confuse.
Very different, crucial distinction. Neurogenic shock is hemodynamic. It's circulatory collapse from losing sympathetic tone after a high cord injury, usually T6 or above.
And the hallmark sign is?
Hypotension plus bradycardia. Low blood pressure and low heart rate together. That combo screams neurogenic shock. Differentiates it from a hemorrhagic shock, which is usually low BP, but high heart rate.
And treating neurogenic shock means aggressive BP support.
Absolutely. Need to maintain MAPs, mean arterial pressure, often above 85 or 90, to perfuse the injured cord and minimize secondary injury.
Okay. And spinal shock?
Spinal shock is purely neurological and temporary. It's the loss of reflexes, like the bulbocavernosus reflex, anal wink, and flaccid paralysis below the level of the injury right after it happens.
Temporary dysfunction.
Exactly.
Yeah.
It usually resolves in 24 to 48 hours, even if the underlying cord injury is permanent. There's no specific treatment for spinal shock itself. Its resolution is important because that's when you can truly assess if the injury is complete or incomplete, finalize the HA score.
Makes sense. And the overall treatment strategy for acute SCI, minimize secondary injury, early decompression and stabilization seems to be the trend.
Generally, yes. The exact timing is still debated. You mentioned the Stacy's trial. But the consensus, especially for incomplete injuries or clear compression, leans towards getting the pressure off the cord and stabilizing the spine relatively early.
And sometimes the fastest way to decompress and align, especially with jumped facets, is traction.
Often, yes. Close reduction, using skeletal traction. Gardner-Walls tongs, usually. Every resident needs to know how to do this safely. Technique 41.3 in the book.
Okay, walk us through the protocol. It's not just hang weights and hope, right?
Definitely not. First, position the patient carefully. Head of bed up 30, maybe 40 degrees. Helps with the pull vector.
Okay, then the weight.
Start with a calculated initial weight, usually 8 to 10 pounds just for the head itself, then add about 3 to 5 pounds for every cervical level above the injury.
So C6-7 injury, you add weight for C1 through C6 plus the head.
Correct. Adjust it a bit for how big the patient is. And then this is critical. You add weight incrementally, and you must wait at least 5 minutes between adding more weight.
5 minutes minimum. Why? To let the muscles relax.
Yeah.
Overcome spasm. If you just pile on weight quickly, the muscles fight you, and you risk over-distraction or worsening the injury.
Okay, so add weight, wait 5 minutes, check neural status, get an x-ray, repeat.
That's the cycle. Neuro exam and lateral C-spine film after each weight increase until you see reduction or you hit a predetermined maximum weight, often 60, maybe 80 pounds, or if the patient's neuro exam worsens, then you stop immediately.
All right, let's shift out to the periphery. Knee stuff, starting with something super common. Meniscal tears and repair. Success seems all about blood supply, location, location, location.
It really is. The Miller-Warner-Harner classification, you see it in figure 45.31, is fundamental for deciding whether to repair or resect.
Breaks it down by vascular zones?
Exactly. You've got the red zone, outer rim, fully vascularized, best healing potential, then the red-white zone, the transition area, some blood supply, and then the white zone, inner avascular area. Very low healing potential. Usually gets resected if torn there.
Okay. Now here's the fascinating part. The healing rates. Isolated meniscal repairs, meaning you just fix the meniscus, no other big ligament surgery going on.
Yeah.
The success rate is kind of,
Disappointingly, man. That's a good way to put it.
Yeah.
Often quoted around 50, maybe 60% successful healing for isolated repairs. Not great odds.
But if you repair that exact same tear at the same time as you're doing an ACL reconstruction?
Night and day difference. The healing rates jump dramatically, up to 90% or even higher in some studies.
90%, that's a massive difference. 40 points or more. Why? What's the magic?
That's the million-dollar question. Two main theories get kicked around.
Okay.
Theory one is biologic augmentation. When you drill those bone tunnels for the ACL graft, you release marrow elements into the joint growth factors. Cytokines, stem cells, pluripotent cells. Basically, you create this Rich biological soup, a healing response.
Like a fertilizer boost for the meniscus repair?
Kind of, yeah. It enhances the fibrin clot at the repair site, makes the whole joint environment more conducive to healing. That's one popular theory.
What's the other theory?
The other idea focuses on the type of tear. It suggests that maybe isolated meniscal tears are often inherently different, maybe more degenerative, happening in slightly sick tissue from chronic wear and tear.
Ah, so the tissue itself wasn't as healthy to begin with.
Possibly. Whereas the meniscus that tears during a big ACL injury, that might have been a perfectly healthy meniscus that just failed under massive force during the knee subluxation event.
So it's healthier tissue being repaired in the ACL scenario.
That's the thinking. Healthier tissue plus the biological boost from drilling. Whatever the exact reason, the clinical observation is undeniable. Concurrent ACL reconstruction significantly improves meniscal repair success.
Fascinating stuff. Okay, moving to ligament testing. Valgus stress test. Standard for MCL.
Standard check for medial collateral ligament injury. You do it at 2 angles.
30 degrees of flexion first.
Yep, 30 degrees isolates the superficial MCL, the SMCL, as the primary restraint. You apply valgus force, push the knee inwards, and see if the medial side gaps open.
And you grade the opening.
Right. Grade 1 is less than 5 millimeter opening. Means some fibers are torn, but it's mostly intact. Grade 2 is 5 to 10 millimeters, bigger tear, but still a firm endpoint.
Yeah.
Grade 3 is more than 10 millimeter, feels like it just keeps opening complete tear.
Then you test again in full extension. Why?
TED in full extension is critical. If the knee gaps open medially in full extension, that's bad news.
Why bad?
Because in full extension, the MCL, the posterior oblique ligament, POL, and the cruciate ligaments, ACL or PCL, are all tight and contributing to stability. If it opens here, it means you likely have a massive injury involving not just the MCL, but also the POL and potentially a cruciate. It indicates a much more severe global instability, likely a knee dislocation that reduced.
Got it. Extension laxity, well, big trouble.
Big trouble, multi-ligament injury until proven otherwise.
All right, finally, let's tackle the dial test. Tibial external rotation test. Figure 45.52 shows it. This one feels a bit more complex, but key for the posterolateral corner, right?
It's a really elegant test when done right. Helps differentiate isolated posterolateral corner PLC injuries from combined PLC and PCL injuries.
How do you do it?
You have the patient prone or supine. You flex their knees to 30 degrees and then to 90 degrees. At each angle, you maximally externally rotate the tibia by turning the foot outwards, and you measure the foot-thigh angle.
Comparing side to side.
Critically comparing to the uninjured side. A difference of more than 10 degrees in external rotation compared to the good side is considered pathologic, abnormal.
Okay, 10-degree difference is the magic number. Now, the interpretation depends on when you see that difference, right? At 30 or 90 degrees.
Exactly. Here's the key. An isolated PLC injury, meaning the PCL is intact, will show that pathologic 10-degree increase in external rotation at 30 degrees of flexion.
Okay.
But not at 90 degrees, or much less rotation at 90.
Why not at 90?
Because at 90 degrees, the intact PCL provides significant rotational stability and compensates for the injured PLC. The PLC structures are most important around 30 degrees.
Makes sense. So if the PCL is also torn...
Then you have a combined PCL and PLC injury. In that case, you'll see the pathologic 10-degree increase in external rotation at both 30 degrees and 90 degrees.
Both angles show increased rotation.
Right, because now, without the PCL helping out at 90 degrees, the knee just keeps rotating externally. That finding at both angles is the classic sign of a combined PCL-PLC injury.
That's a crucial distinction. Changes the whole reconstruction plan. But there's a warning, a caveat with the dial test.
Very important one. A cadaver study showed the dial test might be falsely positive, or at least unreliable, if the medial side of the knee is also unstable.
If the MCL is torn too.
Exactly. If you have significant medial laxity from an MCL tear, the whole tibia might just rotate more freely, potentially mimicking that 10-degree difference even if the PLC is okay, or making a PLC injury look worse than it is.
So you can't interpret the dial test in isolation.
You shouldn't. You need to correlate it with your medial exam findings, especially that valgus stress test. If the medial side is solid, the dial test is much more reliable for assessing the PLC and PCL. Hashtag tag outro.
Wow. Okay, that was a pretty intense sprint through some absolutely essential surgical playbook elements.
Yep.
We hit the fixed geometry of PI, how it dictates lordosis, the specific kind of scary progression rates for adult scoliosis, that critical 79% nerve strain risk and the last half of a spondy reduction, the whole trauma workup with NXUS in Asia, And then the biomechanics of why meniscal repairs heal better with ACL surgery, and how the dial test sorts out knee instability.
And that's really the level of detail required, isn't it?
Yeah.
Mastering these granular points, knowing the average PI is 52 plus or minus 10, setting the NNT of 167 for MRI in certain trauma cases, understanding precisely why rotation increases at 30 but not 90 in an isolated PLC tear.
Yeah.
That's what separates just being familiar with the concepts from actually having the competence to make the right decisions in the OR or clinic. You got to know the numbers, the mechanics, the risks.
Absolutely. So here's a final thought for you, the listener, to chew on based on what we discussed. We established pelvic incidence is fixed. It sets the requirement for lumbar lordosis. So consider a patient with a high PI needing significant lordosis. They undergo a long spinal fusion, maybe T10 down to the pelvis. But the surgeon doesn't restore enough lordosis. They leave the patient with a significant PILL mismatch, say, more than 15 degrees difference.
Okay.
What are the predictable long-term mechanical consequences of that mismatch? Think about where the stress goes on the spine above the fusion, on the screws and rods themselves. What happens when you fundamentally violate the patient's inherent spinopelvic geometry? Something to really think about.